I invite Dr. Vivek Srivastava to welcome everybody, please.
Yeah, sure. Good evening, good afternoon, and good morning to all their respective time zones. Welcome you all to the symposium on winning over the two C's, COVID-19 and cancer. When it comes to cancer, we are aware that cancer patients are an extremely vulnerable population because of their disease and their cancer type of treatments. And the data so far available indicates that they are more susceptible to the coronavirus infection. Very invigorating issues, and since almost a year we have been somehow talking about. And they are more likely to suffer serious life-threatening complications from COVID-19. Now, after the promising vaccination news, which is coming across the world, in fact, from different countries, and a lot of developments are also happening, still in continuation and reputation of it, it becomes extremely important to have multi-layered discussion related to cancer, COVID-19, and vaccination. We, as per its fundamental tenet, is on learning or educational programs with evidences-based responsible nutrition, which we call E2RN, which is earnestly working on learning and discussion in the same flow and context. I am extremely delighted to welcome expert faculty to reflect their stance and perspective on the topic. And I'm feeling favored to have Dr. Purvish, who is the moderator, to set the tone and face this so very important topic for winning over the two C's, COVID-19 and cancer. Dr. Purvish is a Group Oncology Director, Shalby Cancer and Research Institute, and Director of Precision Tech Oncology and Research, Asian Cancer Institute. He is the Executive Director, Indian Cooperative Oncology Network. Dr. Purvish was past President, SARC Federation for Oncologists and Indian Society of Medical and Pediatric Oncology. Dr. Purvish has authored almost 19 books and written 35 chapters in different books and more than 200 scientific articles. Now, without further ado, I pass it on to Dr. Purvish. Over to you, Dr. Purvish.
Thank you, Dr. Srivastava. Let's straight get into the thing. These are the broad agenda for today, and we'll start with a brief idea about the COVID status and progress. What's new? So there's a lot of lessons learned, and one of them is how to do virtual academic activities, as we publish in the Indian Journal of Medical Sciences, which is a journal that was started in KEM Hospital. So all of us are familiar with that. And the way that we are doing a webinar today is based on our experience of what we should do. Now, as was, we were discussing in the chat before the conference started, there is always this fake news factory on social media. And this is one such example. On December 25th, just last month, this was the headline: Qutub Minar illegal construction. Now, obviously, all of us know that can't be illegal because there was no law at that time. But what they meant was that around Qutub Minar area, there was a lot of illegal construction. So this is how we are getting misinformation and miscommunication about COVID and the vaccine as well. So if Dr. Anita Ramesh is here, has she joined? Anita, can you share your thoughts about how we are dealing with this misinformation about COVID and the vaccine that we are having there? If Anita is not there.
Yes, I am there.
Go ahead, Anita.
I'm there. Yes, I'm there. I just reached. Okay. Excellent. So the thing is that this misinformation is going on, and that also will help us. But it's also not helping us to go forward. Like lot of different miscommunication between the safety of the vaccine as well as the how is the efficacy of the vaccine, because some of the vaccines have not completed the phase 3 studies. Also, we do not know the long time data. We do not know about the other complications which can affect all of these. These are so many of the unknown data which is not available. And and also this has a political cover up, which is also creating a lot of difficulty. And many lay people will not know. And also it's being a clinical trial. We heard what happened in Bhopal. And many of the common people will be miscommunicated. So that is causing a hindrance. But then there are several aspects of the hindrance. I told you 5 to 6 points, and it can be more than that. But what we need to know is that how to tackle them, how to go forward, how to make awareness among the general population, that, okay, this is what, but all said and done, sanitizer, mask and social distancing still remains the gold standard, whether you get the vaccine or not immediately. That's what I feel.
Right. Akshay, as an ID specialist, what are your comments on what Anita just said? You'll have to unmute yourself. Yeah, go
Can
ahead.
you hear me okay?
Yes.
So in US, we have problems of these so-called around fake news situation. We call it myths and facts, and we are still struggling with that. There are three kinds of people in US. One is people who will take the vaccine on the first day, first in the line, like myself and many other people. The second group of people are quote unquote anti-vaccine people. And the third group of people are, I might take it, but I want to see how other people do, whether they have any problems, and then I'll join the line or climb in the running train. So that is happening. However, the challenging part is the misinformation that you pointed out floating around, and it is very challenging. A lot of people, unfortunately, some speakers and YouTube information and what have you, and of course, all parts of media is floating information that it changes your DNA, it affects your fertility, it affects placenta, it can cause COVID virus. I mean, there are numbers of myths floating around in some of the medicals. So we have to constantly educate.
Right. So this is just to show you when the COVID first cases were identified in SAARC countries as opposed to the Western countries. And you can see that some of the countries like Sri Lanka and Bhutan actually had their first case as late as in March, as opposed to January, where most of us had the first case. Now, this is 2 days ago, the daily new cases and the daily death schedule. And you can see that the second wave or the second peak has been really causing havoc all across the world. As in contrast to this, what is happening in India is quite different. And you can see that we are having a steady drop in the number of cases. And this is for number of new cases per day. And similarly, it is for number of deaths per day. So this is something which is very surprising as opposed to what is the experience in some of the other countries where the large number of problems are there. I was going to ask this question to Jaideep, but he is not able to join. So Dr. Ajay Bapna, can I ask you?
Yes, sir.
Yeah. Why do you think that in India, steadily all the cases are going down as opposed to not having a second wave as is seen in some of the other countries?
Could be, sir, probably most of the population have understood the importance of social distancing, masking, and other measures, non-vaccine measures, which we need to really adopt. So they have become quite educated by this time now.
Prashant,
what is one of the reasons, sir?
Right. Prashant, are you there? Can you unmute yourself?
Hello, sir. How are you, sir?
Yeah. Go ahead.
So this is a very interesting question, and we had a few thoughts on the same, and that was just at the outset, at the beginning of the pandemic, and we actually analyzed some of the factors which could be, we were optimists at that time, and there is an article we wrote, and Purvish sir was a part of that article, and Dr. Shah and some of my colleagues, and we looked at some of the population epidemiology and demographics and the blood group, and also we did some genomic analysis of there was some data on some like viral genome associated with malaria, Plasmodium malaria, and that was integrated into the genome of Plasmodium, and we found that there was some base pair, 8 base pairs which were matching with the spike protein of the coronavirus, and that was a very interesting finding. Although I'm not saying that is something which has led to low number of cases in India, but that was a hypothesis at that time. And subsequently, in the last few months, we actually have noted that there has been a significant drop in India despite having such a huge population.
Correct.
And despite being so vulnerable, all of us, crowded, but still there is something different about India, which has led to a fewer number of cases. Now I think there's a time when we probably can conclude that yes, there have been problems with our patients especially, and it has been difficult logistically. So I coined this term called para-COVID. So COVID was a problem for India, is a problem, but a bigger problem has been para-COVID. So para-COVID is all the paraphernalia, the logistic problems which come along with COVID. And that is what has disrupted India much more. And especially our patients, their transport, their travel, their access to healthcare, access to care of cancer patients especially, that was disrupted. So coming to some other points like ventilation theory, that was Dr. Shah Agrawal's input out actually, and he hypothesized that because the Americans and the Europeans, they are living in more of closed environments, and they are not well ventilated. That's why the possibly the number of cases may be there more there, and infectivity maybe the contagion is spreading more because of the closed environment. And India, we have windows open, we have less of air conditioning. That was his hypothesis, and I kind of agreed with that, and we put it as a point in our article as well. Also, the difference of blood groups. There was some data from China initially that the B blood group people were having a more severe disease, and in India there are more of O blood group people, just a prevalence of blood groups. It was just a prevalence analysis, and we found that there is a difference of the blood groups composition of the population as regards the blood groups. All these were hypotheses at that time, but we were all still optimistic. So the hypothesis still holds on, and we can look at that again in the context of now where we are. Yeah, thank you, sir.
Okay. Yogesh, you are looking after more than 100 healthcare professionals under you. Did you have difficulty in ensuring that you are able to, implement the necessary precautions for COVID? And was there any particular reason why you think that a second wave has been so resurgent?
Good, Purvish. Thank you all. Yeah, so even amongst healthcare, which was surprising to find out that the acceptance of the simple measures, what we all been talking about, mask and social distance, took some time, and of course the obvious thought in the US, as Akshay mentioned, was it because of our leader that this time Trump? And then it could be, but I think it goes deeper than that. It's not just the Trump or the Trump followers, but also just the value, American value, which has recently changed, not believing in science, not believing in CDC or the World Health Organization. So yes, it did take some time for healthcare providers to follow, even in my place, not as bad as many other bigger places.
Right.
The surprising part, Purvish, came when the vaccine were available. In mid-December, when the vaccines were available here, and we started asking healthcare providers. In the community, I knew community was not open in the US. It was either 50-50, we'll take it, or as Akshay mentioned, maybe even 30%, only 30% of minorities, African Americans or Black people in US would say, yes, we'll take vaccine. But even in healthcare, it was almost 60-40. 60% took it, 40 not, because of similar reasons, what Akshay mentioned, or that they were positive. So it is a little bit shocking, but that's what the reality is.
Yeah, even in Mumbai, if you take the example of KEM Hospital, the dean of the hospital said, "I'm not ready to take the vaccine." So it has been really, all over the place.
Sir, can I interrupt, sir? Dr. Bapna?
Yeah, go ahead.
Sir, recently, just few days back, a couple of days back, we had a program of, the trial of one of the Indian vaccines in SMS Medical College, which is the largest, medical college of the state.
Yes.
And none of the medical professional took the vaccine.
Really?
Yeah. None,
Right.
none means none.
Right. So, Sahoo, this question is for you. You have always been skeptical about the adequacy of testing. And some of the people say that the numbers are less in India because we are not testing enough. So what do you feel?
Sir, I feel the 2 points to it, the 2 parts to it. Yes, we are not testing enough. And if you look at the way we have tested, most of the testing in the later half has been because of the rapid antigen test.
Right.
And that really picks up very less number of patients. So that would contribute to a large number of the patients who would be there but not in the data. Second, I don't have evidence to what I'm speaking. It's more so of the hearsay with the friends which I have in the administration.
Yes.
Not all cases are getting reported. So I would not be able to give you proof to that, sir. I put that disclaimer there.
Right.
So because of the political pressure what we live in, not all cases are put in the data. Number two. Number three, I still feel, sir, the death is a data which we cannot be manipulated. So one fact is that our death rates are low. That cannot be ever, there's no controversy to that. We may have more infections, that would be milder infections, but somehow our severe infections has been lesser. That is one thing we should thank God for that. I don't know what has contributed to that, but definitely, sir, testing is a thing. We have not done enough RT-PCRs like the Western world has done because of logistics, because of finances, whatever it could be. So our numbers are definitely low because of that. The second thing about the propaganda, a small thing to it. I've been in Bhopal, the Covaxin, the huge cry is happening for last 4 days. The media is full of the trial things. I think there is a propaganda against vaccines. They had a press conference yesterday. They came out with all the facts. There is a committee set up by the state government that came out that no things were ever done wrong in the trial. So and even to counter Dr. Bapna, 10% of the patients or volunteers in the Covaxin in Bhopal were medical students or medical professionals. So it is not that, it is different, but yes, there is definitely a group which is playing against the vaccine thing. That's for sure.
Right.
Purvish, a question to either Sahoo or Prashant. Is there any studies, Prashant or Sahoo, about the ACE receptor bindings in Indians? Is it less binding compared to other communities around the world? If the severity, what Sahoo you mentioned, if the severity and the deaths are lower, is it anything to do with
I really do not have any data on that. But what I wanted to say is that we may tell that we have underreported it because we are not tested enough, but death is definitely reported. So that won't be missed. So that is something that has saved us from this pandemic. But I don't have answer to you. So if sir can take it or anyone else has some data on that.
So I also don't know the answer to Yogesh's question.
Just
Anand,
I had one comment.
Prashant, go ahead.
Just on sir's question, Dr. Shah's question. I have one thing to say that I came across some data on Hla association with severity. And that is particularly from the time of the SARS-CoV-1, and there are known Hla associations with severity with probably SARS-CoV-2 also. So the HLA of the Indian HLA, it is bound to be different. So there could be some that could be one factor which could be leading to maybe less severe disease. It's difficult to say, but I'm not aware of any data on ACE receptor binding in India. I don't think there is any such data. At least I'm not aware of it.
Right.
So, Dr. Vamshi, yes, sir. I think, sir, one thing we have to actually, I've been agreeing with Dr. Sahoo, but there has been definitely some amount of underreporting, but that's true across the world. I mean, you look at the US data, you look at the UK data, even they did not have clear evidence to begin with. But as time went on, we started having a better data. And now I agree with Dr. Sahoo, you can't hide deaths. It's not that simple. Definitely at the peak and before that, I think we have missed deaths, definitely, but that's true across the world. Look at Brazil, look at Mexico, they are very openly announcing that they're missing cases. So it's been now normal. That's how everywhere it has been. We cannot point a finger at India and say we have done this. It's been the norm everywhere.
So this is
the second issue, sir, about the.
Go ahead, Vamshi. Vamshi, go ahead.
Regarding the second issue which Dr. Yogesh was raising, one thing is our population is a much younger population. So that is one reason why the total percentage-wise still seems to be a little lesser. If you see in the Italy, around 30% of deaths initially were those above 80. And that is a population not really very, very high in India. So that's probably one reason why percentages are lower here.
All right. So when we are talking about the deaths, I think the frontline workers, like all the healthcare workers, doctors, nurses, have also had a high incidence of death. And you can see these are the top 10 countries where doctors and nurses have died. So this is also a problem in India. You can see that in India at the time in August when this was reported, 87,000 health staff were infected with COVID. And the number of deaths in doctors as opposed to non-doctors is a dramatic difference. So, Anand, I come to you. In the UK, is the incidence of deaths more in the healthcare professionals as opposed to the general population?
Well, up till now, you have mentioned that we had about, initially it was quite large because we didn't have PPE and people were working. So we started getting cases in end of February, March. So we started having quite a lot because for 6 weeks, I think we didn't have, all hospitals didn't have PPE, though we had PPE in East Kent. For some reason, my hospital and Nandita's hospital, we had PPE from day one, which was good. But yes, all those people who died were from black and ethnic minorities, healthcare workers initially. Probably 80 to 90% of them initially in the first 3 months were more of black and ethnic minority.
Right.
Healthcare workers.
Right. Akshay, in
there
the
is
US,
a study going on in UK of the 673 deaths up till now, till end of August, of the healthcare workers, which will come out at some stage.
Akshay, in the UK, you are, I mean, USA, you are looking after a large group of ID specialists. What are the challenges that you had in implementing policy to ensure that doctors and healthcare workers do not fall prey to COVID?
You asking me?
Akshay there?
Okay. Yeah, Purvish. So you are asking the challenges for prevention of the infection in healthcare worker. As Anand pointed out, you can split this question into two phases. The one which was the initial surge in March, April, and May, and then now, because everyone all over the world, we have learned a lot of things over a period of time. But in the initial surge in the first 3 months, one of the biggest challenge was we ran out of PPE. So that was a disaster. I have never seen any time in my 36 years in US that you didn't have enough gown or you didn't have enough mask. That was challenging. The participation from physician or healthcare workers was absolutely phenomenal. Everybody pitched in. Everybody was heroes everywhere, as all over the world. But the biggest challenge, I would say, was the PPE supply.
Right. And there was also the challenge of not only doctors being infected, but also their relatives or people living with them, immediate family also being affected. And I know of several families in India at least, who 3 people were admitted at the same time, and then unfortunately one of them passed away.
Sir, one thing, Sahoo,
go ahead, Sahoo.
So one thing which I feel the doctors, the death rate of the doctors being at a higher percentage could be because of the amount of viral load they would have taken treating these patients, and that probably will be one of the logical explanation for that.
Very true, very true.
Purvish, one point on that for us is the healthcare worker, when they get infection, we look at all the epidemiological factors, and what we have found all over the country, most of the time, it is physicians or healthcare workers bringing infection from the community. It is not spread within the hospital.
Got it. Right. So everything that we had anticipated as disaster preparedness went wrong, and so many experts had their reputation on the line. Now, one question that comes to my mind is, what is China hiding by not allowing the WHO team to go there and identify where was the origin of the virus? But we'll leave it at that, and we don't want to spend much time on that.
So they're going on 14th, sir.
Right.
The WHO team is there.
Finally, that's good news. So the Time magazine has honored the guardians of the year, that is the healthcare workers. And in that same issue, there is a very good article about how Uttar Pradesh government has made some COVID management innovation. Now let's move on to the first-hand experience of tackling the UK variant strain, and that is Dr. Mrs. Divekar. She has been at the front line where the highest incidence of COVID patients admitted for 5 consecutive weeks in the hospital. And I think it was really amazing. She was at the epicenter at the Medway Maritime Hospital. 5 weeks of highest incidence, working 12 to 14 hours daily in the PPE suit. Hats off to her dedication and spirit. And let's listen from the horse's mouth about what exactly she had faced and her team had faced.
Sorry, Purvish, can I come in for 2 minutes?
Yes, go ahead.
Hi, I'm Nandita Divekar. Sorry, I can't come on. I have to go back into my PPE soon. I just came out about 10 minutes ago. And thank you very much. But if anything is there, I might be able to come out again after about 10-15 minutes, and let's see what I can speak. So thank you very much for having me on this meeting.
Right.
Thank you.
Because she is on duty today, so we recorded her presentation, and that we'll request the team to show the presentation now.
Gentlemen, namaste from the UK. I am Nandita Divekar. I'm a consultant in anesthesia and critical care in Medway Hospital in Kent in the UK for the last 22 years. And today I will be sharing my experiences with COVID from the front line. I have been involved in the first wave as well as the second wave in the management of patients personally. So in this talk, we will be talking about incidents in UK, the issues in our hospital, our practical experiences and management of patients, and one slide on my vaccine experience. So why is it important? Globally, there are more than 87 million cases, deaths about 1.9 million, 2.9 million cases, deaths about 80,000 in the UK. And just yesterday, 68,000 cases positive declared. Now, why is it very important? Because in the UK, the case rate is about 619 per 100,000, which is increasing every day. I work here in Kent, and then in an area called Medway Towns, which is Gillingham, Chatham, Sittingbourne. And if you look, the case rates for Medway is about 1,167, increased by 292 over the last week. Deaths rose by 82% in December. And I've been working all throughout in the Medway Hospital. So please imagine our plight. And again, hitting the news, the new variant of COVID-19 is a hugely more transmissible than the virus's previous version, a study has found. The UK's latest R number has been estimated between 1.1 to 1.3, and it needs to be below 1 to the cases to start falling. What it says further is the new SARS-CoV variant is growing rapidly. It's more transmissible than other variants and affecting a greater number of population under 20s. And it will make control more difficult, and it further accentuates the urgency of rolling out vaccination as soon as possible. The absence of the S gene target in an otherwise positive PCR test appears to be a highly specific marker for the B117 lineage, which is now designated as a variant of concern. New variant caused a surge in COVID-19 cases. This is again hot off the press on the 5th of January from the Lancet in Respiratory Medicine. And that said that in Kent, cases continue to rise despite the lockdown. In September 2020, 1 in 4 cases were due to the variant. In December 2020, 2/3 of cases are due to the variant. Schools were closed. Now it's lockdown. Schools are being closed. Schools were not closed at that time. And therefore, we are worried whether keeping the schools open was one of the causes. 45 countries have now reported variant. So what happened in our second wave? Our wave started nearly in October when winter set in. It was predicted, but we were hopeful that it wouldn't come, and we weren't prepared. We have normally 9 level 3 or ventilatory beds and 15 high dependency beds. So what did we plan? We had to do capacity planning again, increase those to 50, perhaps more. And we then had to, convert our recovery room which can accommodate about 8 to 9 patients into intensive care beds, our theaters into intensive care beds. What's happened during this wave? Last time, everybody was really enthusiastic. Now, nurses are tired, doctors are tired, exhausted, low morale. We have job vacancies. There are staff isolating. Senior rota, we have to change again. We are doing resident on call at nights, and we have got really, at times, I'm supposed to go for a resident on call duty for 14.5 hours or more, and I'll be in my PPE for more than 12 hours. PPE, we have been very lucky that we've been getting PPE, and I've got good PPE. I wear my hazmat suits, etc. Imagine Medway has had the highest number of cases in the UK for the last 5 weeks. The lateral flow test kits have been given to staff to test asymptomatic staff as well, so that we can detect nurses or doctors who can get asymptomatic infection and might infect the rest of the ward. This is my PPE. This is my PPE suits, and I feel safe in it. And I've got a different mask now. This was from the last wave, but because that's also was a problem because those masks are no longer available. But we are far more busy than the last wave. It started coming in October, surge in the second, third week of November. And guess what? That was my weekend on call, 72 hours without sleep, continuously. It was really, really busy. According to the Intensive Care Audit and Research Center, the age group which has been found, the recent report suggests that the age group was similar. However, now if you see, we are finding that many, many younger patients are coming. We had 2 patients who are just 27 years old, and that's why it's very important to tell our younger ones as well, be careful. Don't think that you will not be affected. Ethnicity, again, it was saying that last time Black population was quite badly affected, but this time the Asian figures are the same as last time. So BAME population have been affected badly, but Asian population have maintained. So we have to be careful. And patients are presenting late. They're like last time, they were presenting within the first week of symptoms, but now they're presenting after about 1 week of being detected positive. More non-invasive ventilation for longer periods of time. That's what we are experiencing. So what have we done? We have done that the capacity has increased. We have expanded to our recovery room. We have stopped elective operating, and we have expanded to theaters as well. We have transferred patients more than 200 miles, and the nearest beds have been in Bristol, which is about 200 miles from us, or it has been in the north of the country. We only get that patient is COVID positive. We are not told whether it is the variant of concern. So that's very important for us to know. The patients get admitted. What happens when a patient arrives, it comes to hot resus. Sometimes they have their test in the community, and if they don't have their test in the community as positive, then we do the point of care testing, which is the SAMBA test, which is simple amplification based assay, but it is beyond the scope of this lecture. They're assessed by ED doctors. We have assessment criteria for high dependency and to admit to intensive care. Then it's decided a treatment escalation plan, whether ward-based care, level 2 or level 3 care. What happens? Patients requiring oxygen therapy, we start them on steroids, antivirals, VT prophylaxis, unless suspicion of PE. There is a treatment escalation plan, and refer to the respiratory team if there is any deterioration. And if patients are requiring higher level of oxygen, then we have to change. If you can see the VT prophylaxis, what we give, the enhanced VT prophylaxis, we then consider them for the recovery trial. We have been admitting patients and then randomizing them if they allow us. And also alternate days, we do COVID blood panel tests, mainly CRP, PCT, ferritin, D-dimers, troponin, LDH. And if required for ventilation, then we refer to the anesthetic team or the intensive care team to come and assess. Now, we as doctors have got 2 meetings or 2 to 3 meetings. In the morning, we meet, we hand over at 8 o'clock, and that includes all the juniors and seniors. Then after we do all our ward rounds and we finish, we come out at around 1:30, and we have a meeting from all the doctors, from respiratory physicians, us, as well as the high dependency physicians. Everybody gets together as much as possible to discuss which patients require to be admitted, which patients are admitted on the respiratory ward, which patients are admitted outside who are on non-invasive ventilation. And that's how we decide who is and what is their level of care. And latest on this, we have the REMAP randomized embedded multifactorial adaptive platform trial for community acquired pneumonia. And this has come just yesterday from the government of England as well, and NHS England saying NHS patients to receive life-saving COVID-19 treatments that could cut hospital time by 10 days. This trial shows that the drugs reduce the risk of death by 24% for critically ill patients and time spent in intensive care. BMAP trial has shown that mortality was 35.8% for patients receiving current standard of care alone. And this was reduced to 27.3 using tocilizumab and sarilumab. So there is a 24% relative reduction in the risk of mortality for patients who've entered intensive care. Had by vaccine, full course done, hooray. All frontline staff are invited by the hospital, mainly according to the risk assessment. It is free for everyone on the NHS at present, not available privately. We had the injection and then we were monitored for 15 minutes. It wasn't very painful. I'm scared of injections. It wasn't very painful at all. Was rung up for the second appointment 3 weeks later. And if you look at this, this is the card, which I have as well with my signature. And apparently that's my passport for flying if later on. Post-vaccine, I spoke to quite a few of my friends. What they said is mainly either they had no symptoms. Mostly people had myalgia, soreness, fever, chills, and headaches. And post-vaccine too, my symptoms were slightly worse and similar to the above, but I felt very, very sleepy and a bit nauseous as well. Some people reported just bad gastrointestinal symptoms. So it's just, I rang up all the friends and had a discussion with them, and that's what we came up with. So what do I think? Will COVID go? I don't know. Certainly it's not going in the next few months from UK. I hope it does. It's still haunting us. People are very scared. Will they take it to their families? Will their families be affected? We need to maintain social distancing, wearing masks, washing hands. It will save lives. And please warn young people because they think that nothing can affect them. And I've seen the worst.
All right. We'll go back to the continuing with the presentation. If I can make the slides move forward. Yeah. So now we are going to focus on USA and UK experience. What are the differences and similarities with respect to India? This is just a photograph of the Pfizer vaccine that was being given at Oman, shared by a friend of mine. Now, all of us know how a pandemic can act. Either it can kill all the human beings, it can kill the infective agent, a cure is identified, immunity in the target population, or vaccination, which is the main focus of today's webinar. So hand over to Anand to share his experience with the UK NHS Foundation Trust. Anand, over to you.
Yeah, can you all hear me?
Yes, we can.
Yeah, just to mention regarding my wife Nandita, apart from doing the excess work she has been doing for about 3 months since March and now for the last 5 weeks, she has been in doing webinars nearly more than 20 to 30 since May throughout the world. And she has been giving lectures and she has been preparing for that. So literally, she has worked 2 or 3 times her normal duties since the pandemic started. And you go to the hospital because there are lots of deaths, there are audit meetings, there are mortality meetings, there are management meetings, and there are policy meetings, planning meetings, and PPE meetings. And to be frank, there is never ending work for ITU people. And I think the ITU people are the most worked people up. I'm not saying doctors, nurses, as well as staff and the management nurses in that. So I'm just mentioning it is very hard. It is literally hard to take into all these considerations. And to be frank, she has done lectures and conferences all throughout, and during night time in Dubai, in Manila. So, but now the recording has started. The technology is getting better now. So it's not that critical that you have to sit for the whole conference at the time of the conference. So that was my just contribution. I don't think she would have told you this, but she has worked really hard and she's still working. So this is what my topic is going to, my lecture is going to contain. That this is as per request by Purvish. I'm going to talk about the Swedish COVID plan. Then I will give the timeline in UK as far as the lockdown test R rate and the healthcare worker deaths are concerned in UK. I'll be talking only of UK. That's what I know. And then I will talk about what vaccines are in our area and in UK. And why we took it, and I'll give you the same take-home message, which is going to be the same as Nandita has mentioned and others have mentioned. So what happened? Everybody, we came to know about China, Wuhan virus, probably in the end of December in UK. We were not that worried. We said it's a bit far off. And then gradually the cases started getting worse and worse and worse. And then China, Wuhan got into lockdown. Then Singapore, Taiwan, and Korea, we were all listening all these things. And we thought it might not come or it might stop somewhere in between. And then Germany happened in February, France, and then Italy was the worst. And then we knew it was going to come. And by that time, by February, some cases were coming in UK. Then just to tell about Sweden, what Sweden did, the report came in September, they did not have a lockdown. They had the policy of slowing the spread of the virus and not stopping it. And the main policy they had was social distancing. And 98% of the population, they say, according to the report in September, that they changed their behavior, social distancing. In fact, if you go into the detail of social distancing, they were so careful not to talk face to face with each other, despite having 2-meter distance. They were sitting diagonally in the restaurants. They tried to meet only one person in the pubs or restaurants and not 3 or 4 people, so that they could talk slightly away from each other. Because the government had still not given, they were not compulsory on the face masks. Though people said that they were still doing the hand washing and using face masks, but the government had not made it compulsory for the mask to wear. But social distancing was very important as far as the restaurants and public spaces were concerned. Next slide, please. So what happened? Our R rate started going up in March. We were about between 2 and 3 reproduction rate. And so we had the first lockdown on 23rd of March, where everything was absolutely closed, apart from key workers, essential workers, healthcare workers, and patient had to go for appointments. So that lasted till about 15th of June. We had government briefings by officials every day at 4 p.m. And we came to know what exactly was happening day-to-day deaths, cases, as well as hospitalization and ITU beds were discussed. By 15th of June or slightly earlier, the R rate went down to 1. And so the government relaxed some of the restrictions and 6 people could meet outdoors and the non-essential shops opened. And between 15th of June to about first to second week of September, we were okay. Everything started opening up. We started doing our elective list and our elective clinics as well. Because from about first week of July, the schools closed, universities closed. From July to end of August, everything was closed as far as education was concerned. So, and it was summer as well. But once the school started in September and the university started, we started having problems again. And then we realized that the people who went to university for the first time, they were having good time meeting in pubs, and the cases started rising in northwest of England, which is Liverpool, Yorkshire, and Lancashire. And so the government started tier system, which is 1 to 5, 1 being the least number of cases being positive in 100,000, and the 5 being the maximum. So we realized that the cases were rising, and we had the second lockdown from 5th of November to 2nd of December. And it was a variable lockdown in the sense people with tier 4 and 5, they had stricter lockdown, which was mainly in Kent and London and Liverpool, Manchester and Yorkshire area. Well, some people did not have any cases at all, like in the Southwest in Cornwall and Devon. So they had not much of restrictions. But then we realized that something was happening, and some cases by second week of December, suddenly the cases in Kent, our area, they were just increasing. More and more cases were getting detected, and my hospital and Nandita's hospital, especially Nandita's hospital, were getting absolutely packed with COVID cases. And so we had the third lockdown. We started from last week, 6th of January onwards, and they are going to review it on 23rd of February. With regards to test, the first PCR test was available for us in UK on 21st of May. That is literally 2 months later. And the lateral flow test, which you saw in the video there from my wife, was given to all of us on 12th of December. So I have one box with the test at home, and my wife has. So we have to do it as healthcare workers twice a week. It has its own problems, but at least we know that we are not positive. At least 70% chances that we are not positive. But it was very useful for universities and mass screening. What happened just before the universities closed on 15th of December? All the students, more than 60, 70, 80,000 of students, or more than that, had to do this test, and only when they were negative, they could go home. Unless you had the certificate from the university, you could not go home unless this lateral flow test was positive, which was a good thing. So we knew when my son came home on 15th of December, he was negative. So, so that was a good thing. And then just regarding the R rate, as I mentioned, the R rate in March of 2020 was around between 2 and 3 in some places it was nearly 3. In October, when we had the tier system, where we had the second sort of semi-lockdown in certain areas, it was 1.3. And right now it is increasing from 0.8 to 1.2 to 1.3. Probably today it could be 1.4 in the whole of UK. So the first death due to COVID in a normal citizen, not a healthcare worker, was on 13th of March. And then the first 2 doctors died on 29th of March. We had no PPE by that time in their hospitals. 11th of April, another 19 more deaths. Again, in those places, we know that because they said there was no PPE for them. And 25th of May, 130 deaths. 20th of July, total 313 deaths. And by 11th of August, we had 620 deaths in healthcare workers. So now we have 2 vaccines which have been given to the population and healthcare workers. My hospital and Anita's hospital were the first to get the Pfizer vaccine. And it was, they started giving us from 7th of December to healthcare workers. So I had mine on 8th of December. Nandita also had around 8th or 10th of December. I won't go into the details of what it is. It has to be stored at -80 degrees, and it given 2 doses. And then the Moderna vaccine has been approved now, and it is going to be given end of March to April. Of course, they all say that the efficacy of all the 3 vaccines is going to be 90 to 95% after the second dose, 3 weeks after the second dose. And after the first dose, it is about 60 to 70%. And the main reason everybody has been taking, or I'm taking, is to prevent serious illness or death from COVID vaccine, or from COVID disease. Why did I took it? Both of us have taken 2 doses now. My second dose and my wife's second dose was on 7th of January, just on last Thursday. And of course, we had decided to take it because Nandita, as an intensivist, could get a heavy viral load some stage. And if the mask at that time is not fitting properly or something has happened, she could be in very bad danger. So we had decided to take vaccine, whichever came to us first. And there was a problem few days before the 7th of December that few patients had some allergic anaphylaxis. And so because it was in my hospital and her hospital, we were ready to take that risk, because I'll be in my hospital setting and people will immediately know, and I'll probably get both of us will get the good treatment immediately. By the time 7th December came for the injection, there were 2-3 more strains discovered. So we thought we might get some immunity from them, though it was not proven by the pharmacology department for the companies. And of course, we needed some immunity because we both work in the hospital, and our hospitals right now are full of COVID patients. They are asymptomatic as well. So, and we both were willing to take risk of immediate and long-term adverse effects as well, rather than be critically ill and die of COVID. Nandita, having seen so many deaths, sudden deaths, young deaths now who come, they are breathless, and within 2-3 days they are on ventilator and they just die with no treatment being effective. So we both had 2 jabs now of the Pfizer vaccine, 8th of December and 7th of Jan. I have been taking the flu vaccine since last 11 years. Every September or October, I'm one of the first ones. I have taken flu vaccine, so I know what symptoms I get. And despite having flu vaccine, I suffered from flu about 4 times. But the symptoms and the severity was very, very mild as compared to what I had before the flu vaccine came to UK to be given to some of us. Of course, after the first jab on the 8th of December, I had injection site pain, arm pain, flu-like symptoms, body ache, but I was used to it. I was expecting it, so it was not a problem. I took paracetamol, but it lasted for 24 to 48 hours. So I did not work for 1 day because I knew I would not have be able to drive and walk and see patients. So I took 1 day off. The second dose affected me quite significantly, to me and to Nandita as well. And we both had taken leave before that as well, the next 2 days, because we knew it was going to be bad. So we had taken leave, so it was okay. But it lasted, both of us took it on Thursday. So till Monday afternoon, so 3-4 days, I was in the house. I didn't feel like doing anything, did not eat much, and took regular paracetamol, and we were okay by after the 4th day. So I'm absolutely normal now. So at the moment, today I was reading nearly 2.4 million doses have been given of Pfizer and Oxford. The Oxford vaccine has been started from 4th of January now. So nearly 2.3 million people have had vaccine, first or second dose, and we have not had a single hospitalization or anaphylaxis from the vaccine. So that my take-home message is take the vaccine and continue with your hand washing, mask, and social distancing. Thank you.
Right. Thank you, Yogesh. Before you run away, can we ask you your experience of taking the COVID vaccine, please?
Sir, Dr. Yogesh is not online, sir.
Okay, then we can take Akshay. Can we take your opinion? You have taken the vaccine, right? What was your experience?
Yes, Purvish, I took Moderna, and I have taken 1 shot, and the second one is due in 1 week. So, as everybody knows, the first vaccine causes less side effect than the second one, and from the trial, we know that the second vaccine has caused more side effects in younger populations. So Anand must be younger than his age to get more side effects, probably. But my second one is due 1 week from today. And the first one was minimum, just local site pain, headache, body ache, lasting for about 1.5 days. So It was very easy. In our in US, the distribution and allocation is from government. It goes from central government, it goes to state, and each state allocates to each hospital. So some hospitals, like my hospital, got it Moderna, and other sister hospitals, they got Pfizer. So I took Moderna, what was available in my hospital.
Right.
In US, there are about 6.5 million doses given as of yesterday. And about what I heard last was about 29 anaphylaxis, but they all recovered, and many of them had prior anaphylaxis history. So looks like it's pretty good safety.
Right. So let's go on further to the COVID vaccine. Finally, we have light at the end of the tunnel because the COVID vaccines are available to us. Just to give you a brief, there are 43 vaccines in phase 1, 20 in phase 2, 20 in phase 3, and approval has been limited for 7 and full approval for 3. So in addition to all this, there are 172 vaccines in the preclinical development even today. And as Akshay was mentioning, the number of vaccines, if you look at the highest number of vaccines, is 9 million in China. It's 6.69 million as of 8th January in United States. And then you have countries like Israel, United Arab Emirates, and Denmark, who have got a significant number of vaccines. But if you look at the number of vaccines per population, per 100 people in total population, actually Israel is number one, and then is United Arab Emirates and Bahrain of all the countries. This is what Bill Gates said about what India is doing about the COVID vaccine. And this is the statement from our Honorable Health Minister Harshvardhan, that the intention is to vaccinate the entire population. This is the Covishield, that is the AstraZeneca vaccine that is being manufactured by Serum Institute India and is available in India at a cost of 200 rupees plus tax. And on the top right hand side, you can see the shipment, the courier shipment that is started as of yesterday for this vaccine to be shipped all over the country. So this is vaccine hesitancy, and in Indian survey, it said that 69% of Indians remain hesitant. And as you might have seen on the chat, many of the doctors are also hesitant. So Sahoo, I come back to you. What is your opinion about vaccine hesitancy in the general population as opposed to the healthcare population?
I think the general population is more hesitant than the healthcare. For me, I can speak. I'm really very interested to take the first dose. We are starting on 16th. I called up actually CMHO today. Are you giving me on 16th? So that is the eagerness which I have. Awesome. It makes sense. And the best available to me will be Covishield, and I think we will be getting Covishield here. And I think we should be taking it because some amount of protection is better than no protection. Mask will be there. We have been doing it for a year now. We'll be continuing to do it for a year. But I think the hesitancy is there. We are in the chat is very much clear that some of the doctors, colleagues are still hesitant. But I feel this is going to be a big boost to the fight against Corona. And we need to train and show to the public that it is safe. That's why we are taking it. So please come ahead and take it in the future.
I entirely agree with you. Is Anita online? What is the opinion of what is happening in Tamil Nadu and the South?
Tamil Nadu and South, again, our figures are reasonably quite good with the higher recovery rate of almost 96 to 97%. But I think overall, people do maintain the social distancing marks and all. Regarding vaccination, yes, everybody is eagerly waiting because the state is going for election in a short while. Okay, so many of the political factors are also included it, and the government is, as with the ruling government in the center, is also in lines. And I think we are all prepared, and those who are not prepared will slowly fall in line because the initial shot, whether even if they want the vaccine, they cannot get it. It's only for the healthcare and the high risk individual. And slowly, by the time comes or their routine time comes, everything might fall in line because they'll see the others doing well. But in Tamil Nadu, everything is reasonably quite.
So one more thing.
Okay.
One more thing why I will take it is, sir, I don't want the severe infections. I'm getting into the close 50s, sir. And I know that I'm getting into the risk group, sir. I'm hypertensive. I would not like to fall into that COVID positive, go to severeness. We had a doctor, very senior, who was going for lung transplant yesterday, airlifted from Bhopal to Chennai. So you want to get the vaccine to not get into the severeness. The transmission is a very different thing. I would take it because I don't want to get a severe COVID in the future.
Ajay, Bapna, what is your opinion? And then I'll come to Vamshi also. Ajay, Vamshi, whoever is.
Yeah. So I really agree with Tarini that even if we get the infection, the severity will be much less, and we can manage those kind of severity, but not the kind that you need to be put on ventilator or some kind of mechanical ventilation.
Right.
Yeah, that's my main point.
Vamshi, what is your opinion?
So, I am all for the vaccine. I think as a whole country, we do need the vaccine. Yes, it's difficult to vaccinate the whole country, but we need to get it. So I don't think, and regarding the cases in Hyderabad, we are lucky. Telangana does have comparatively lesser cases. There was a period in August, September when we had much more cases than was actually being reported. That's true. But numbers seem to be less now. But irrespective of that, we need to get it, and I think people will be reasonably okay. I don't know any data, but most people seem to be eager enough to get it. So I think that shouldn't be a problem.
Excellent. So how real is herd immunity? And Prashant had also already mentioned about whether Indians are already immune. So we'll skip that. This was a survey that we did. There were 311 responders, and these were all doctors. So if COVID vaccine is available to you today, will you take it? And 72% said yes. That is 224 out of 311. Who should receive COVID vaccine? And again, the majority said that all individuals should take it. This is COVID vaccine necessary if you have got the COVID in the past? And the answer is still, you can see 57% said yes, if there is no protective antibody, and 35% said yes, irrespective of the antibody.
Sir, in the last slide, I think there is a point to make that antibodies should not be the way to predict the vaccine, because there are 4 antibodies available. We do not know, and they're looking at very different parameters. We do not know which one is protective. I think majority of us are getting it wrong. And if you go to literature, they're very clear. We should not be looking at antibodies at all.
I totally agree with you. Thank you very much, Sahoo, for pointing that out. This is the one that is always puzzling me. Should children be vaccinated? And you see the answers are all over the place. And not a single child, or at least anybody less than 15 years, has ever been vaccinated in any of the trials. So how do we say that vaccines should be given to ages of 5 and so on? So this is something which is a puzzle to me. Should COVID vaccine be mandatory before international travel? And 65% said yes. And I think Dr. Mrs. Divekar was also showing her ID card that would allow her to travel internationally. So that is a good thing. This was just for a sort of lighter question. If the vaccine is available in UK but not in India, should we go and there? And you can see that actually 29% would be willing to go there. And I think that was a really nice answer on the survey. So if you are given a choice, which is the vaccine that you would put? If you are given a choice. So Akshay, let me start with you.
So the answer is any one of them right now. Today, in COVID, we said that whatever you say is truth of the hour, because in next hour you may have new information. So right now in US we have only 2, Pfizer and Moderna, and they both seem to be quite parallel. In the clinical trial, there were minor differences of percentage of people with the side effect, as everybody knows. So if I had a choice, which one I would pick from what is offered, either one of them.
Excellent. Anand, what about you? If you had a choice in the UK?
Yeah, but same answer, to be frank. Yeah, all 3 vaccines, whatever is available. Our hospital had the Pfizer, which came to my hospital, and I was willing. If it was Oxford, I would have taken it. If it was Moderna, which came in, I would have taken it. I think everybody should take whichever is available in their area and hospital, rather than given a choice.
Right. Anita, what is your opinion? Anita, and then Ajay, Bapna.
Yes, sir. We need to rely the policy of the government of India, because it must the document must have passed through the technical experts.
Correct.
So I believe them, sir.
Excellent. How do you have a different opinion?
Sir, I feel we have 2 choices. That's a Covishield or a Covaxin.
Yeah.
I will go with Covishield at this point of time, because I have data. Whatever the efficacy, let it be 70%, 65%. I'll go for it till I see the Covaxin data. But I think I will go with it. I will take whatever is available. But given a choice, I'll go with something which has efficacy data. That's a small point.
Right. Perfect. Now, this is what Anita was mentioning, that everything becomes politicized. So Akhilesh Yadav is saying we cannot take the BJP vaccine. And then the statement made on national television is that we should not take the vaccine because it causes impotency. So these are all irresponsible statements, and their consequences can be really bad. And fortunately, the good sense prevails, and the official from the Drug Controller General has made positive statements and rubbishing all the rumors that have been there. Now, this is one good positive thing about the Indian vaccine. So Brazil, both the government sector and the private sector are purchasing vaccines from India. The government sector is purchasing the AstraZeneca vaccine made by Serum Institute in India, and the private clinics are purchasing Bharat Biotech's vaccine from India. So I think this is something that we should be all proud of. Now, this is about this delaying the second COVID vaccine dose, and I think Anand, you can tell us, is it the right thing to do, or is it just out of compulsion because there are not enough doses? What do you think is the thinking behind the delaying of the second dose in the UK?
It is, as far as I'm concerned, in UK, I'm talking about they had to delay it because they wanted to give as many people as possible 60 to 70% efficacy. Because the virus, the 3 strains, the 2 strains is spreading so widely now that we need to have maximum people with 60 to 70% efficacy and give just 1 dose. And that's the reason they are delaying. I was lucky in the first people who had the first dose in the 2nd or 3rd week of December, they are getting the Pfizer vaccine at 8 weeks now. And people who got the vaccine, Oxford vaccine from 4th of January, they're getting it at 12 weeks now. I think it is a public health psychology. It's not individual. So, and just today morning in the one of the journals I was reading, one of the infectious disease doctors said it is possible that the more you delay it beyond 4 weeks or 8 weeks, it might give you more immunity. On what basis he has said, I don't know. But I'm happy with 60% efficacy. I was happy not to take the second dose if there was some reaction to me. But at the moment in UK, I feel that's a good decision. Yeah.
Okay. And Akshay, as our ID specialist, what do you recommend? You'll have to unmute. Yeah, go ahead.
Yeah, I disagree. And not only me, but most of the infectious disease experts, we had a national call on Sunday to discuss this UK decision and what should we do in US. Most of the experts believe that we should try to do 2 vaccines and not delay the second vaccine. So most of the people are voting against that policy that UK has done. And right now, like this week, we have little shortage of allocations. So our hospital and many other across, they are completing the second dose and holding the new first dose. So we have a different, we are taking a different approach. However, as everybody knows, on 20th January, we have change of leadership. So how that will affect after 20th January, whether we will have a different thought process, don't know.
Right. Excellent. So what about people who have already been exposed to the virus and have been hospitalized? Should they be receiving a vaccine or not? Akshay, again, I'll start with you first because you are our ID specialist.
Sure. So Purvish, one more time, repeat the question.
If a person has already been exposed to COVID and he is positive, he was admitted, now discharged, should he receive a vaccine or not?
Yeah, so the answer is the CDC and ACIP, they had a lot of meetings about this, and the answer is right now, the way we are handling is the person who has already got COVID-19, he or she will have antibodies. And we know that the reinfection is very rare for 3 months. Latest data is showing maybe up to 6 months. So the current guidelines in US are, if a person has COVID, then he or she should delay for 90 days. However, if a person desires to take it, then we are offering them after the contagious period is over. However, we are strongly recommending them to wait for 90 days. The rationale behind it is that somebody else who doesn't have antibody, they should get the chance first. And the person who has COVID can wait up to 90 days.
All right. Prashant, what do you think India should be doing about patients who were already diagnosed with COVID earlier?
So Prashant sir is locked out.
Okay. Sahoo, can you take that question?
Yes, I feel it makes sense. And actually the antibody is there till 3 months. It is just a strategy to cover more population.
Right.
But ultimately, all which should get vaccinated. That's what it is. And the expert also told that we just because we have antibodies, probably we can give the other one who has not got the infection the opportunity.
Right. Ajay, you are there?
Yes, sir.
Okay. Now, this is something that I want your opinion on. Why is China importing COVID-19 vaccine now? If you look at the reported cases, they have no new cases since May 2020. But they have developed a vaccine, but there's no public access of Chinese vaccine safety data. And still, a pharma company from China is importing the Pfizer vaccine. And the Chinese government is actually promoting a trial of the Pfizer vaccine in one specific province in China. So, Ajay, what do you think is happening in China?
Yeah, so should I suspect that they are in anticipation of a second wave?
So it's such a mystery what is happening there. We really don't know. And as Prashant was saying, that the WHO team is visiting China on 14th of January. Let's hope that they come out with something.
So if China has second wave, we are also going to have it.
Right, right. Let us hope not. Let us hope not.
Yeah.
Small corrections. Just last 2 days, they have reported again a big rise in 300, 500 cases in one province next to Beijing.
Right.
Yeah, Vamshi.
But sir, how do you believe China, sir? There is so much of censoring of data. How can you just believe that they control everything in a month and the whole world is not able to control for 1 year, sir? I don't believe.
Very true. Very true. Very true.
Sahoo, be prepared for a big news soon.
Right. So now let's move on to.
I cannot trust China news at all. I don't know how genuine whatever you have presented, Purvish, is true or not. It could be just some political whatever. Yeah.
We don't know. That's why I'm just putting this up so that
I know. Yeah.
Now
sir, can I ask one question before we move to the last part?
Please
so there is something in the literature about should we be taking more than one type of vaccine, because they're looking at very different things in the things like we are looking at mRNA with the Moderna and the Pfizer. We're looking at the spike proteins.
Yes.
We're looking at the inactivated vaccine for the Bharat Biotech.
Correct.
So should we be taking beyond one? What is the expert? Because I would like to learn from here. Should we be at some point, if the things come that, okay, after 6 months, we take the other one, the protection actually grows? I know the answer, most of it we don't know, but what is the big sense telling us?
Right. So I didn't have the time, so I took away the slide, but there are 6 or at least 6 different types of vaccines available in the terms of manufacturing methodology. And if Akshay is still there, we can ask him, is it right to take one mRNA vaccine and then another inactive vaccine, or is it right to take one intramuscular vaccine and another nasal vaccine? Would that improve the immunity?
Yeah, complete the schedule definitely for each one.
Yeah.
So the current guideline and thought process is, if you take one type of vaccine, even within mRNA, if you take Pfizer, then second dose should be Pfizer. If you take Moderna, then you should take Moderna. So question doesn't come whether I should take one method and then take the other, because it doesn't make sense.
Sir, the question is different, sir. We do agree that you should take to complete the course of a vaccine. You take Moderna or Pfizer because of the mRNA technique. Let's take now the inactivated whole virus is coming from Bharat Biotech. So do you take that also after that is over at a particular time? We don't have evidence to that, but what do you feel?
Yeah, so I think we don't have any data for that. And whether or not it will even help, we don't know. So if you go by the simple science, if you have enough neutralizing antibody to the spike protein, then why would you need another vaccine is the question. Whether anybody even are planning to do this kind of study of doing one method and then giving the volunteers another one, that is yet to be seen. But if I have to give advice with the thought process of science, doesn't make sense.
Right. Let's move on to this. Now the new terminology has come is Covid. And those are people who are idiots who do not follow the social distancing norms. And in India, I'm sure all of us agree that there are several places like what I've shown here, where it is impossible to have even 6 millimeters of space, forget 6 feet of space. So we still need to continue emphasizing that a face mask, hand washing, and social distancing should still be mandatory even while the vaccination process is going on. Now let's come to cancer, COVID, and vaccine. Vamshi, I will start with you. What is your opinion? should COVID vaccine be given to cancer patients? Is the efficacy same as a non-cancer patient? What about teen and young adults? And what are the different types of cancer patients who should or should not get, based on whether they are on active treatment or whether they have completed treatment long time ago?
So, the simple answer, if you want a hard evidence, we don't have. We have to
Right.
extrapolate from what evidence we already have for other vaccines. And by and large, what I would say is, if patient is on active treatment right now, I would not give the vaccine. Patient has completed treatment and is a survivor, definitely they should take the vaccine.
Right.
If patient is planned for a BMT, is a post BMT on any immunosuppression, again they should avoid it.
Right.
Hard evidence for any of them I may not have, but I think that's the general way of doing.
Anita, what is your opinion?
Can I add, sir, something, Dr. Bapna?
Yeah, Ajay, please go ahead.
I sort of quite disagree with what Vamshi says. The patient on active chemotherapy also should receive it, either prior to the starting the chemotherapy or in between the 2 cycles. That is the recommendation by the ASCO and IDSA, and which was reinforced by the US CDC also, that the patient on active chemotherapy should also receive the vaccine.
Right. Sahoo, what do you think?
I'm all for that. I think, except for if you have the live attenuated, other than that, I think we do give it to the cancer patient. So why not? I think I would give it.
Right. So there are some evidence about both vector and killed vaccines being safe in immunocompromised patients as well. And this is there are several organizations like Ajay Bapna mentioned, like here this is the ICML Foundation that says that it is appropriate to give patients of chronic myeloid leukemia COVID vaccine. Now, it was always challenging to get good quality trial data, and during the COVID pandemic, some of the clinical trials have gone for a toss. So we don't really know what is the validity or what is the robustness of the data that has been collected. And this is something that we will have to face in the future. Now, this is something which is very interesting. We found that as the pandemic occurred and as a lockdown occurred, while tier 1 cities had difficulty in, health hospitals were not getting non-COVID patients. This is an example of how chemotherapy administrations actually increased in tier 2 cities. And I think this is because the cancer patients, either newly diagnosed or on treatment, were not able to travel to a nearby tier 1 city and had to forcibly take the treatment in their own city. So, Sahoo, what is your experience of this in Bhopal?
Yeah, definitely. I think I did not have an increase. Probably I didn't have a dip in my patient load.
Right.
And it made sense because patient felt probably more comfortable in Mumbai or Delhi, but could not go there. So that's why they continued in tier 2 cities.
Right.
That could be the only logical explanation.
Right. Ajay,
Yes, sir, we were too inundated with the patients who couldn't travel to the metros. I think I have discussed it with you earlier also.
But sir, it makes more sense to have an article on this. Yes. Has the cancer care been affected if you don't go to metros?
I think that will be really nice.
Tarini is really revolutionary.
So what about reinfection? As Akshay mentioned, that the incidence of reinfection is very low. But is it something that we should be worried about, or we should just take it casually? Akshay, what is your opinion?
So the information is evolving, Purvish, and we don't know how long the antibody due to COVID infection or antibody after the vaccine will last. And we are learning as the information comes out. However, when a patient presents after COVID, after 1 month, 2 months, 3 months with COVID-related symptoms, what should we do? So that we know that the person already had COVID and now looks like it is COVID-related symptom. Then the current thought process is that it is extremely unlikely for 90 days, and the latest data about a week ago, it might go up to 6 months. But if you have a patient, what do you do? So if you have a patient, then you can do the RT-PCR test, and right now in US we have a way of sending it to CDC for genome sequencing. And if the genome sequence of that isolated patient is similar to genome sequencing of the first, then you know that it is the same variant, and it's probably persisting non-viable virus. But what can I do in Livonia, Michigan, and to save time to sending it to CDC? So then there is a information evolving. Some of you probably know about it, called CT value. So what we do is we do the PCR test after second month, third month. And if the patient is still positive, then I call up my virology head and he will tell me the cycle threshold value. And cycle threshold value is inversely proportional to viral load, as all of you know. And if my CT value is about 33, then I know that viral load is very low. And we make this decision case by case for reinfection. Having said that, the true reinfection with a different genome sequencing, like a separate virus, is common within 3 months, but it can occur after 3 to 6 months.
Got it. Got it. So, are the oncologists at higher risk while treating their cancer patients who are also COVID positive? Sahoo, let me start by asking you.
Sir, I had some 6 or 8 patients who I treated when they're COVID positive, because government made my hospital also COVID positive mandatory. So I took all precautions, and lucky that I did not have it. But yes, I think the OPD has to be less crowded. We take the same precautions, and till now saved. But I did find that a lot of oncology friends did get COVID.
Right.
So it's very difficult to answer, but I'm not sure that but I feel, sir, if I very truthfully tell you that a direct contact of a medical oncologist with a patient sometimes is not that huge. You look at reports, you look at the patient, till the patient is really sick in the ICU, don't spend that amount of direct contact time. Right. And I think that has saved a lot of us.
Right. Ajay, what has been your experience in Jaipur?
Yes, sir. The increased risk is basically from the asymptomatic carrier who are entering, in our OPD without the screening for COVID-19 patients. And, the precaution, I think we need to treat every patient whosoever is entering in our OPD as a suspected COVID-19 patient.
Right, right. Vamshi, what is your opinion in Hyderabad?
So for me, the bigger challenge was actually from patients who just walked in and then, removed their mask in front of me and then said, I'm suffering from fever. It was more common problem rather than actually patients. I personally did not manage them. They were in the ICU, and like Dr. Sahoo said, just go see the reports, and we were keeping a distance away from them.
Right, right.
That's about it.
Right. So one of the things that Dr. Mrs. Divekar said is that there is going to be a very high incidence of post-traumatic stress disorder in healthcare professionals. And this was one survey that we did among lady healthcare professionals only, lady doctors and nurses. And do you intend to make significant change in your work-life balance? And you can see that more than half of them wanted to make a change. I'm not sure that they will actually do that. But this lockdown and the pandemic has taught us lots of lessons. Akshay, what do you think about convalescent plasma therapy? Is it useful, not useful? In what is it useful?
Right. So convalescent plasma therapy had its own course from March, April, May, June, July, and until now. We were desperate when we were started using it. However, the issue with convalescent plasma has been a few, and that is there is no standardized antibody titer. So it's a blind approach. You are giving it from somebody hoping that he or she will have antibodies, and you are giving passive antibody therapy to someone. Right. Now, since then, and of course, this is a group of hematology oncology, so I don't have to say, but there were reports about increased thrombosis in some patients and what have you. Having passed through that phase, now in US, at least, we have this monoclonal antibody available. So right. For high-risk patients, within 10 days, we are offering monoclonal antibody, Bemleni, VMAB, and also the combination monoclonal antibody treatment, which is widely available, free of charge to any patient who fits the criteria. So the role of plasma therapy has gone down.
Right. Sahoo, have you used convalescent plasma therapy?
No, sir. No, sir. What I hear of from my colleagues who have been doing it in the medical college in the respiratory specialist, they are not very happy with the outcome. But yes, there has been debate. There's a debate going on.
Right.
Yeah.
Ajay, Bapna, what about yours?
Yeah, in our state, the SMS Medical College was at the forefront for treating the COVID patient, and they really propagated, this plasma therapy too much.
Right, right. And Vamshi, in Hyderabad, what is the situation? Vamshi is not there. Okay. Now, Akshay, we discussed about your expertise in which patient requires steroids and which doesn't. And Sahoo was mentioning that one doctor had to be airlifted from Bhopal to have a lung transplant. So this is one such photograph of a patient doctor who underwent a lung transplant because of pulmonary fibrosis that has occurred because of COVID. And this was a photograph from Max Hospital in New Delhi. So Akshay, specific question, we'll have a greater discussion on this later, but in 1 minute, can you tell me your insights into the use of steroids in patients with COVID?
Definitely. Let's try to do it in less than 60 seconds. If I have to give a take-home message, if you look at IDSA, NIH, CDC, all the societies guidelines, they are all based on recovery trial, which is published in New England, which everybody is very familiar with it. And all societies in US are consistent in recommending steroid only when oxygen saturation is below 94% in the hospital setting, because we admit everybody who has desaturation below 94. What is the problem is some of the primary care physicians are giving steroid even when patients are stable with high oxygen saturation. And if you look at the recovery trial, that is the segment of patients that had little more mortality, not less mortality. So the word of caution is there is a limited therapeutic window when the steroids are useful, and that's after day 7. There is a data in recovery before day 7, after day 7, and patients who are desaturating. So the caution is to use it in the right patient at the right time.
Got it. Got it. So now, thanks very much, all the faculty. Please stay around because we have a question and answers. I will stop sharing my screen and we'll take some of the questions. I think there were more than 100 comments and questions, but we will see what we want to. Can we go to the next one? Next one, please. Is fatality rate the only reason for vaccination? Akshay, what do you say?
No, answer is no. Fatality rate is not the only reason for vaccination. Vaccination, as Anand pointed out, or somebody else pointed out, is to prevent COVID disease. We know that we don't know whether it will prevent the asymptomatic transmission, but we know that it will work to prevent COVID disease with 95% efficacy.
Right. Can we unmute Sibashish? He wants to ask a question. Sibashish Bhattacharya, can we unmute him? And we can go to the next slide, please.
Sir, I think so. AZ study from Oxford has the only trial slide about the transmission, sir, data.
Next. Okay. Sibashish, are you still there?
Yes.
Okay, please unmute yourself and ask your.
I am always thankful to Professor Parikh for giving me opportunity to talk about the important issues all around, and great respect for him. And it had been a very good discussion till now. I send the message also. In West Bengal, we have already received our dosage of Covishield, 7 million or 7 lakh dosage, and it will be distributed among the healthcare workers in a manner. But thing is, today only I have read that 11.1 per million.
Ashish, we lost you. So Prashant has asked a question: how should travel and social contact guidelines be different from vaccinated versus not vaccinated? And I think it should not be different, because it is impossible to segregate vaccinated from not vaccinated. Anand, what do you think?
Yeah. We are telling patients that whether you have vaccine or no vaccine, social distancing has to be maintained. You have to behave the same way as if in a lockdown. So there is no difference.
Right.
No, I just wanted to tell that hypersensitivity reaction, allergy, adverse events, that recovery from the adverse event, that mechanism should be in place, because it takes place within half an hour. So all the vaccination centers should have the anaphylactic tray ready before starting vaccination, because
Absolutely right. Totally agree with you. Akshay, can you take Ravi's question? He's asking, if I do antibody test and I'm positive, should I have a sufficient titer, should I postpone or defer my vaccination?
So the answer is, we don't know the optimum level of antibody needed for neutralization. The utility of antibody tests so far is only one. It tells you that you had a past infection. It doesn't time the infection, and it doesn't tell you what is the optimum level of antibody. We don't know. The studies are ongoing. So the answer is no. We are, as Anand pointed out, in UK or US, nobody is doing antibody tests prior to vaccination that I am know. Definitely in US. So it should not be done, and wait for more data. If you had COVID infection, for sure, documented, then you can wait for 90 days. That's the current guideline.
Right. Next slide, please.
I think the quality and quantity of the antibodies, we don't know. Two of my colleagues had COVID. There were no antibodies 3 months later when they did it, the antibody test.
Absolutely. So antibody test.
And if you have a slight, like if you have a big COVID surge on you, like if my wife is working and she gets a big viral load, then you might get severe antibodies. But if there is an asymptomatic patient or just getting minor virus load, you might not get any antibodies.
So again, to reiterate what should be the answer for Ravi's question, measuring antibody doesn't translate into protection. There are 4 different ways of measuring different types of antibody. We don't know which is more important. It may be that you have got a cellular immunity and you are protected. But today we cannot use the antibody to decide that you are protected or not. And it is better to be on the safer side and take the vaccine so that at least our lives are not affected. Next slide.
Antibody, excuse me, sir, just a point. Antibody is basically a public health survey mechanism. How many population is already affected by COVID? Other than that, antibody test has no clinical implication as on date.
So Asim's question is, what is the rationale for the interval between jabs and the number of jabs? That is, answer is very simple. It is based on the phase 3 clinical trial protocol that they have used. The efficacy of 60% at 1 dose and 90% at 2 doses or 3 doses is entirely based on the protocol that was used. And we cannot deviate from the protocol. That's why I think Akshay was saying that the second dose should not be postponed, even though you might want to have a larger population protected by giving them only 1 dose.
Sir, can I ask one thing?
Go ahead.
Sir, for the Oxford one or the Covishield, for the UK data from 1.5 dose and the 2 dose, the low dose and the standard dose.
Yes.
Does it make logical sense for that? Should the governments not be thinking of a 1.5 dose? It makes more sense. We can have more vaccine doses because it's a vector-driven, adenovirus-driven vector. So the point is that once you give a smaller dose in the first one, the chances of getting or rejecting the second dose will be much lower, and you can generate more immunity. So what is the experts' take on that? Should these low dose be the standard to go ahead, or the standard dose of 1 is the only way to go ahead?
Akshay, I think you will have to answer this question.
Yeah, so it depends on the trial data. Right now, we are a little behind in US because in US, the Oxford AstraZeneca trial, the FDA has asked for more data. So they are doing more data. They are doing further clinical trial, and information will come out by March or April.
But we have the NEGM publication, which shows that definitely there's a more efficacy with the 1.5 data. At this point, yeah.
Sure, no, got it. So outside US, the data I have not looked at, but if the data shows enough efficacy, then it will be the protocol. But it all depends on at the end of the day, it all depends on the trial data.
Prasanna has asked, will any of us agree to take Covaxin? Absolutely. If I have only Covaxin available to me, I will be more than happy to take it.
Sir, only one point, sir, to be fair to science, because we're speaking science here, sir, and the scientific journal. So what is the efficacy? I would like to have a look at the efficacy, and I would like to have that.
So all you have to do is to look at the SEC committee notes, the minutes of the meeting. The entire efficacy data is already there. People are questioning that without taking the trouble of actually looking at the notes. If you go, it is available.
Is it in public domain?
Publicly available, absolutely. You go to the DC.
So would you share
I will forward it to you. I will forward.
Thank you, sir. Thank you,
sir. One point, sir. This Covaxin has been kept as a backup, as per Professor
Rtpcr. Not true. Absolutely wrong. Whoever has made that statement is not correct.
Professor
there is a clarification already there from the health ministry that it is not a backup. The question is, Prasanna is asking, if I had a choice, would I take Covishield or Covaxin?
Yeah.
The Covaxin, go ahead.
And sir, we will need more than one vaccine maker. The one vaccine maker cannot satisfy the whole country.
Exactly.
USA is doing that. So I disagree, sir, Sivashish, sir, with you. It's not a backup. The only point why there's little bit scientific community is that...
No, I am not telling it is a backup. It is Professor Guleria, a top man in India.
But that has been changed. He has clarified. The statement has come. Let's move on to the next question. Please, next. So I would take whichever is available to me first. Same thing Anand had said, same thing Akshay had said. I don't think there is anything much to choose from, even if it is a dead vaccine or a dead particle.
But government is rolling out Serum Institute vaccine in India at present.
Next slide for the question. Are we done with the questions? Okay. Since Dr. Mrs. Divekar was busy in her COVID duties, we had asked her questions and recorded them. For those, it is already past 8:30, so our time is up. So I don't think we will be able to go through the question answers with her today, but that recording will be made available to you. It will be put in a publicly accessible online space, and the URL will be shared with you, so you can go through the question and answer session that we had with the intensivist at the UK. With that, I thank you very much for this wonderful discussion. Thank all the faculty for the intense expertise that they have provided. There are lots of other questions on the chat. I don't think we will be able to go through all of them. And I hand over back to Dr. Vivek for the vote of thanks. Over to you, Vivek.
Thank you, Dr. Purvish. So the last 90 minutes was like, it was thoroughly a wonderful, far out and revealing discussion. And all the panelists has really opened so inapt to share their experience and perspective on the various facets of COVID-19 virus pandemic. I would like to thank Dr. Purvish Parikh for conducting the session so well. It was pleasant. Goodbye and a great week ahead.
Thank you very much. Thank you all the faculty. Stay safe. Continue to be active as a warrior in this fight against COVID. Get your vaccine as quickly as possible if you choose. And if you don't choose, then defer the vaccine if you must. Good night or good day or good morning, wherever you are.